Sorry for being late after some troubleshooting. Now Sally is in trouble because we will do a, I mean, who's just starting? Just we do have the fellows, right?
Yeah.
And it's you're just starting, so maybe you should do the scope, right?
That's right.
Thomaz Fleury from ENT, and I'll be talking about, I guess, the ENT view, especially focused on anatomy and clinical findings for sleep medicine. And it's my pleasure to be here talking to this group. So we're going to discuss why is it so important to make the correct phenotyping of patients, but this goes all the way back to the different procedures, surgeries, and approaches that have been proposed to treat sleep apnea. Even from the classical sleep surgery algorithm, all the way back to 87, we would need to know where occlusion is happening, for instance, if it's in the oropharynx, or if it's oropharynx and hypopharynx, or just hypopharynx, because this will guide how to approach sleep apnea through surgery. Before we should do on 2 phases. So we'll try phase 1, which is focus at soft tissue and advancement of the angioglossus. And if that failed, we'll finally go for a full MMA. Now we have a lot more to offer and we understand a lot more. But all of this comes from understanding of anatomy and phenotyping. And this is really what I think it makes sense to explain to you guys, how we make this decision. I think when you refer patients to us and we decide to go from one surgery to the other, I think that this is where we need to be at the same pace and understand all of this. So it goes back to the same topographic diagnose. If we have nasal obstruction, then we're gonna aim for this, and you know this won't improve sleep apnea, but it does improve sleep apnea compliance. If we have a bigger problem with soft palate, that's where we're going to be aiming. If it's the tongue, and so on. If it's a skeletal, and we're going to be discussing this in a little bit. So really, the key for sleep surgery success is proper airway phenotype. Let's start from outside, facial profile. So just by looking at this patient, and this is one of our patients here, what can you guys tell?
Retrognathia.
Absolutely, significant retrognathia. So what do you expect for this airway? Do you expect this airway to be well,
Wait a second.
stable?
She's breathing okay when she's awake, right? Okay, so what's her airway look like when she's awake? Breathing okay, partially awake, so you have to define partial. I'm sorry.
No, you're fine, absolutely. This is absolutely. So yeah.
So it goes up through the nose, she's breathing through her nose more than her mouth, right?
Yeah.
She's going through her nose, she's going through her nasal pharynx, she's going through her oropharynx, going into her larynx. And you don't know what she has to do that. I mean, maybe she's working with the part, but you can't see that. It doesn't look like she's dyspnea.
Yeah.
And so, you know, she's breathing enough to keep it open when she's awake, but when she's asleep, she may or may not.
Yeah.
There's not a lot of studies that taking a lot of pictures of this, people like this that do lots of sleep studies and finding those that are okay.
Yeah.
And there are those that are okay, not too bad.
Yeah.
But you know, but what do you see when you expect?
So I expect her not to have a lot of support for airway, right? And we can see on head position, she's gonna hyperextend. This is a natural position for patients with sleep apnea. As soon as she's laying flat and falls asleep, she relaxes muscular input. It's expected, not, but Kingman is absolutely right. You can't guarantee, but sure enough, this patient had an AGI. Well, she's young, slim, but she already had an AGI of 23 and very symptomatic. So we use different guides. For instance, we use the thirds to look the division and the symmetry But it's, it's really simple to look at the face and make the diagnosis of a convex face, jaw, especially she's B-retrusive, meaning both jaws are retropositioned, but especially the lower jaw is significantly retropositioned. Chin is underdeveloped, and finally, lips are not competent, not touching. And we use the angle classification both for teeth, but also for profile. It's usually the case that wherever we see on occlusion will be reflected on face. So for instance, we have regular or flat face with orthogonality profile. So this would be, and I don't want you to get, extra caught with the mesobuccal cusp or the groove, but it's just the idea that teeth occlusion is not proper. You're gonna have a significant overjet, and this is what we expect on a class 2 convex face. And then we have the opposite, where most of the cases it's not because the jaw is too big, but it's actually the maxilla that is underdeveloped, and then the inferior teeth will be further reaching the superior teeth, and then we call that class 3. So this is all part of the exam. We'll start by looking at patient's face. We'll describe, and you don't have to go too much in details, but describe the face pattern. Then we're gonna start looking at occlusion. And a big marker is how the incisors correlate one to the other, the superior to the inferior. So overjet is the horizontal discrepancy, and overbite is when one come too much on top of the other. So for instance, that patient, what we had was a significant overjet because of that underdeveloped mandible and chin. So she had, significant, her mid face has overgrown, she has significant gum show, had to do with the lip incompetence. And then, the way to approach and get to the adequate result is by doing the correct profile. So in theory, I can implant this patient, right? You guys refer a lot of patients for implant. If it's the tongue that is collapsing the airway, she could be a candidate for Inspire, but is it the best idea for her, or should we be looking into a procedure to reestablish function, and that will come with a better form? So I'll go over a little bit more on occlusion and how that is important for breathing and for sleep. Specifically talking now about the transverse dimensions, the horizontal dimensions, because we talked about the profile, how the jaws are two-dimensional, but we also have to look how they are positioned when we're looking patient in a coronal sense. So a high arch palate with diminished distances from canine and molars will reflect on a mouth that you don't have enough space for tongue, but you also expect not to have significant cross-sectional areas. So this is also being established as one of the variations in anatomy that can correlate with sleep apnea. So this is just to show how this can be camouflaged. This is also one of our patients, Ben, he's a little bit chubby, he has beard, you can't really tell, but as soon as you look into his mouth, you can see posterior crossbite bilaterally, and this is his superior teeth arch. I mean, how high arch is this? So patient doesn't have a correct tongue position, doesn't have adequate nasal breathing, and these are important anatomical features that you have to look at. And of course, different people have correlated this with occlusion, with severity of sleep apnea, and so on. I won't get too much in details about treatment here, but the idea is making the correct diagnose in anatomy so we can move forward. I really like this picture. You can see during the CT scan, where should the tongue be resting? So when you guys right now, with your mouths closed, where is your tongue? Or where it should be? Usually in palate, right?
Yeah.
So a patient with this, I mean, it's more than arch, it's almost a triangle, right? This is a coronal cut. This is air. Where is his tongue resting? The floor of his mouth. He doesn't have space. He won't properly fit here, right? So the CT really shows that. This is from the planning for surgery. I'm not gonna go too much in details.
Can you just orient again for the CT?
Yeah,
So
absolutely.
what's the triangle? Is that the nasopharynx?
This is the mouth, right?
Below. That's the mouth. right?
Yeah, this is, because I mean, it really looks like a triangle. This is
Yeah.
his palate.
Yeah,
This is his molars
yeah.
here, and tongue that it's usually,
That's
Yeah.
that's but usually a potential space, but here.
yeah, it should be a virtual space, right? In theory, tongue should be resting in contact with palate, but you know, he's a chronic mouth breather. So he's breathing through his mouth and tongue is in the floor of the mouth. And you know, we do all these measurements. Won't go too much in details, but we measure all these distances and we have norms and so on to calculate what would make sense to treat. And just to show, you know, in kids, this is really well established for kids. Dentists will expand as you don't have the suture is not fully closed, but in adults, we usually need to do an osteotomy to allow this junction, and this is during procedure what it looks like. You're gonna have a significant gap, and finally you get to adequate occlusion. Now, we talked about profile, we talked about symmetries, jaw position, occlusion. Let's start looking inside of the mouth for soft tissue. I guess no doubts there. We start by looking at tonsil size, and how much that crowds the airway. Again, by looking at this tonsil, it's more expected patient will have sleep apnea, but a lot of times we see huge tonsils and patients don't have it. They don't have sleep apnea. But usually something like this, crowding the airway, would be my first go-to. It's probably a low-hanging fruit to uncrowd the airway. And then we'll also look at palate and tongue position. So Friedman should be looked at neutral position where he's not, actively changing his anatomy. And then you see how much visualization you have from the palate, starting from seeing the whole of the uvula and the arches to really just seeing hard palate. And then also the tongue, where it's protruded, that's the Malampati, how much you have visualization of the pillars and so on. So we use this. And why is this important? Let me just show you in UPPP how this works. Oh, sorry, a drug-induced lip endoscopy. It's a patient that has really large tonsils, and drug-induced lip endoscopy, it's under light sedation. We'll talk about it in details, but I just want to show here a little bit for what such a huge tonsil will act during sleep. So we're giving light doses of propofol, and all of this airway, you can see this here. I'm looking from above, going down the palate. You can see these meatballs, these huge balls, and all of this should be airway. And now it's really confined to a little posterior space. So once patient goes to sleep, relaxed musculature, you're going to have crowding of the airway. You can see during inspirations, we will consider this close to full closure of the airway. So why is it so important to classify patients correctly? Because if I want to propose a soft tissue surgery, this is going to be a good predictor of success. So this is classical treatment paper where he looked, for instance, at UPPP, and there are many techniques. I won't go too much in details, but patients who respond better to treatment is the ones we put on their stage 1, where they have a good Friedman exposure of palate and they have big tonsils. So these patients are expected to respond to this therapy. And that's why this procedure really, historically people were overdoing it, but they're doing for patients that didn't have the adequate anatomy. So if you suggest to do this with a patient with small tonsils and a Malin you can barely see, you only see the posterior, anterior palate, chance of results are really low. I mean, I won't propose a surgery for a patient whose chance of success is close to 40%. So it really depends on anatomy. One last point I want to talk about before we move to other part of the exam is the phenotyping. This initially was described for E-triple-P for the palatal surgery, but it correlates really well with success for hypoglossal nerve stimulation. So patients who have a oblique positioning of the soft palate tend to respond better to hypoglossal nerve stimulation. Patients who are intermediate, you don't have such good results. And this is very easy to diagnose. You look in the patient's throat and you see what is the palatal position. And finally, patients have very vertical palate. You don't expect them to do as well for hypoglossal nerve stimulation. Just a quick, I know, hypoglossal nerve stimulation is really the interesting topic, but I still think between other surgeries, soft tissue surgeries, including E-triple-P, still have a role, specifically if you select your patients correctly. Let's talk a little bit about nose. As I said, nose is not a treatment for sleep apnea, but it's a treatment for improving airway resistance and with that CPAP compliance. It's a lot easier for a patient to tolerate CPAP if it doesn't demand such high pressures. The nasal mask, it's easier than needing a full face mask with a lot of pressure. So here's very clear how this anterior septal deviation, it's all the way to the columella, and it really changes the shape of the nose. But it's also something so simple to make a diagnosis, and we'll see if that's the case for Sally. We'll look at her anatomy, starting at the nose, and see if she has significant septal deviations, or how big are her turbinates, what is the internal nasal valve. These are all important findings during exam. So it's clear how a septal deviation will limit airway space when compared to septum being positioned in the correct anatomy. Finally, turbinate size. This is, the turbinates are they will engorge and shrink throughout the day. They're responsible for creating airway resistance, but for different reasons, they can become overly enlarged and obstructing the airway. So we'll classify from grade 1 to 4 how much they are occupying nasal airway and how much they are obstructing nasal airway. Let's specifically talk about drug-induced lip endoscopy. Very interesting exam that provides us a lot of information on how the airway is behaving, because everything we talked about is static, right? We're looking at septum, we're looking at palate, but now let's see, once patients in sleep, how this anatomy will behave. I really like making this point because sleep endoscopy has nothing to do with stimulation, right? Every now and then, residents will say, "Oh, I thought this was because of Inspire." I'm like, no, this is way before Inspire. This was described, and it was by a European group, to try to understand what will be the best patients for E-triple-P. This is way before we have hypoglossal stimulation. And the idea is to assess the upper airway in conditions that mimic natural sleep. So we'll specifically look at a few videos, and we'll discuss what that means for Inspire. But I just want you guys to keep in mind that sleep endoscopy, it's a diagnostic tool that precedes hypoglossal nerve stimulation. So the way we classify this, let me see if it's just so it makes, So we'll be looking at, we use the VOLT classification, that V for velum, so we're coming from superior to inferior. Then we're looking at oral pharynx, then the tongue, that's the retroglossal area, and finally we'll look at epiglottis, and we'll classify this from no obstruction to partially obstruct. That's when you have 50 to 75%, and then anything above 75%, we'll call it grade 2 or complete obstruction. This is the classical Kazarian description of obstruction. So, for instance, this is looking at different type of collapse. The V, the velum, can collapse in different shapes and forms. And there's only one that will disqualify you for Inspire. Do you guys know which type of collapse? If we see it, then the patient is not a candidate. It's concentric, yeah, and it's in the volt, right? It's in the V of volt, so it's in the palatal area, and it's this guy here, right? So if I don't see this, can I implant every other type of collapse? I guess the answer is yes, you can. The next question is, should I? Is it any type of collapse outside of this concentric collapse? Do they all have the same chance of responding to therapy? Not really, right? It's a long floppy tube that can collapse in different areas. If I'm stimulating one side of the tongue, how much will I be acting on all these areas? So this is something I really like to bring for a discussion for the ENT and the residents, so they fully understand what we're looking at. So this is just looking at oral pharynx. It has no collapse. Then we have lateral collapse here, then anterior, posterior collapse. We'll look at videos, and I think it will make a lot more sense here. So starting with this, what does this look like to you guys? This is behind the palate. Does it look like a sphincter? It does, right? It looks very circumferential. So this is the no, you can't go ahead. This is the velum collapse. Sorry, the circumferential collapse of velum. So this one is a no. We have all the other ones, that in theory you can implant. Let's look at a few. And maybe we can give Sally some purple foil, and then we do a proper dice. I'm sorry, the quality is not as good as I like, but this is just to show, even as you start, you can see how palate is already, moving towards posterior, and then tongue is also, there's, always swallows because there's stimulation, but as soon as patient is going deeper in sleep, you can see activation. Tongue, tries to activate and clear the airway. This is really what genioglossus activation looks like. Do you guys see this indentation, like this depression? This is tongue activating. That's why patients don't have awake sleep apnea. That's why they have sleep apnea. Because as soon as they sleep and they relax, look how back of the tongue is fully collapsing. So this is an AP collapse, and then comes to a full collapse. So this would be really your best patient to implant. We know we were able to stimulate tongue base. That's what Inspire does, but it also acts on the palate, especially on this type of collapse, the AP collapse of palate. It's capable by the coupling mechanism to pull. Once you move them forward, it's going to pull the palate forward. How about this type of collapse here? This is really coming from sides, right? Yeah. There is no tonsil here. I mean, you can see it's not, tonsil shape, but it's a lateral collapse that it goes all the way from V, but all the way to oropharynx. Everything is collapsing from the sides. Anteroposterior, you pretty much have a stable airway. So how about implanting this patient? So, it's a negative predictor of success. And if they have partial, it's more associated with failure, poor outcomes. So we have now more literature showing how this will not be a good indication of surgery. You're talking about 60% of chance of success. Really not exciting. Oh, I hate that I have to describe what is going to happen, because I want to, but now we're looking at a more inferior anatomy, and we see tongue base here, right? And we can see how tongue base is moving anteriorly, is trying to get out of their way. But see what happened with the epiglottis. It's more and more moving towards the back of the airway, to a point that, with sufficient negative pressure, it will collapse this airway. So you guys know very well how this can be hard to with CPAP. Sorry. Now I can
Dismissed.
I can get, oh, it's here. There. All right. Then just another, and I think I'll catch up here. Just want to kind of show this so we understand, because we still have our patient to look at, but this is just a different type of epiglottis collapse. And you can see it's lack of support from the epiglottis. We call this a folding. So do you think stimulating the back of the tongue will be enough to reposition this? No, it's really not. And we have very low rates of success. It's the lowest response we have. It's a different type of collapse, and we have to specifically treat it. We have ways to do it, done several cases, well, some cases, but looking to do more with Scott. And it's very interesting approach where we can take partial parts of the epiglot, or even be less aggressive and just fixate the epiglottis in a more anterior position. And this is usually enough to stabilize if that's what's dictating your collapse. So this is really the takeaway point. This is just to discuss that patients who have, this is a patient we did at Stanford who had severe apnea, several comorbidities from apnea. And at that point, we could only implant to 65. She was right there. So we decided to do a reposition, but even that wasn't enough. So we have to finalize with implanting. So she needed more than one procedure to get her there. We have, patients who are way beyond what we can do with Inspire. So for those patients, we usually have combined therapy. One way to do it is skeletal followed by stimulation. We would like to think of that as reconstruction to finally do stimulation. So this is, the main points that I wanted to discuss. It really is anatomy, what you look at, what you describe, what you think when you refer patients, or should think if a patient's a good candidate for surgery or not. These are points that we should be looking at. And if you're okay, let's take a good look and see what we find there.
Nose hairs. Want me to sit? Do we have a?
You're gonna be over.
Well, let me see if we just make this.
If you guys have questions with that part, with that discussion, is there anything you want to ask before the fun part?
On the.
Oh,
I guess one question was something, you're changing the anatomy. Do we have a lot of long-term data of like 10, 20 years? These durable procedures, is there any sort of regression? I mean,
Either
the
onto this computer
procedures,
to
we have
or
like.
the station.
That's good. We have some.
Okay, let's try to dock station, because.
And you can lose familiar when we're
Oh, I see.
because we're plugging right here. We actually think it's progressive.
Are you plugged in?
And
Yeah.
the part of the condition
Yeah.
that's worse.
How do we change this page?
Again, but
Oh, it's a button.
let's say, have results lasting for 20 years. That means 20 years, the patient not capable of treating, that you will treat the patient. So the complications will be definitely delayed in the progression of the condition.
Right.
But if we can't guarantee how long patients have gain weight.
Thank you.
Things can change. It is a progressive condition, right? That patient that I showed, the young patient already had all this happening. What do you think her level is gonna be? When she loses.
The whole
effective,
my word here.
Effect of.
So what are some of the
Reasons that works, right?
oral pharyngeal disease,
Oh, okay,
right?
yeah.
Think of those.
You'll learn a new word. Oh, wait.
So, if you're okay, I'm gonna spray after.
Sure.
Okay, and, in the meantime, we'll take a look at that, something that is shown there. I'll just show a little bit of occlusion, multiply and so on, then find a little bit of this in airways. This is probably the worst part. It's really.
So they might work on trying to get it better.
Sorry?
I think it's frozen.
No, it's a flavor screen.
Skills not. There, yeah.
Another way to depolarize this. Is that's right.
Yeah.
Sorry.
Don't worry. No.
All right, so why would this act, if Sally is my patient, Dr. Uranium is my patient, looking at her profile,
And this is done millions of times every day.
how would you guys describe her profile?
I'm with the thirds.
And careful here, you know, especially.
I'm on peace right now.
Very careful.
Just get out of me, not.
Yeah, very adequate profile. Right?
Yeah.
Her jaw position is absolutely, she has class one, she has a nice, jawline, correct chin position, so, you know, there isn't anything out of that. So the next thing I usually, look at.
So actually, that should be your normal, look.
Yeah.
You should say, does this person look like Sally on the? You'll say,
Race reference.
well,
Gold standard, right?
Hey, sorry to interrupt. Can someone stop the screen share for Thomaz's slides so that people zooming in can see the main screen?
Thanks.
Thank you.
You got it?
Absolutely adequate profile, correct position of both jaws. And then I usually, the next thing I'll look for is, occlusion. So just give me a big smile, just to show that. So you see a nice relation between, we'll look at first molar and canines, and you can see how they're, you know, coming nicely as you expect. Nothing, outside or nothing significant there in that sense. Then usually I'll do mouth exam, so I'll have you just open up mouth and you say now, well, let's start with the palate. It's very different from the patients I show, right? I show absolutely high arch palate, canine molar distance significant diminished. She has adequate size for palate, nice position. So now I'll have you say a long and Myelin body, I would call it a, what, we can see some of the uvula, so it's probably a 3, where you see soft tissue, but you don't see the whole uvula there. Then, you know, these are the main points that we're looking at. Now I'm gonna slowly start positioning here. We'll just look at nose, and this is not different from what we expect to see with rhinoscopy, right? Just looking, you can see so much. I'm not even inside, but I can see my turbinates, correct? And I can see the inferior and middle turbinates, yeah, if you want to.
Inferior turbinate, it is here,
Right there,
septum.
septum's is here. There's a tiny little spur here, but overall, the septum's in a very, at least on the right side, is very nicely positioned, right? We can see, and you can see how much airway space we have. Same thing looking at the angle here of the internal nasal wall. It's a nice angle. This angle should be 10, 15 degrees. This is absolutely nice position. I can see, say, ka. I can see her palate moving all the way. I don't know if you guys can see it, all the way from the interior nose. So that means there's no obstruction, everything's cleared out. So let's take a quick look here with it. It's definitely should be a simple exam. Here we have a little bit of a septal deviation. Can you guys see that? How one nostril is a little bit different from the other. So she has a little septal deviation anterior on the left side of the nose. Sorry?
I was just pointing out inferior turbinate.
Inferior turbinate right there. And because, well, also because I sprayed, it's really not congested. You have nice exposure. So
People with allergies love big body.
yeah, and they will, you know, be pushing the septum. They'll be all the way out.
Even after you spray them.
Sometimes even after it's sprayed, it's not as responsive, right?
You're talking about that spurs on the
Yeah,
septal side,
yeah. We have a little spur here and, you know,
but it's not, you know, the main channel is open.
yeah, exactly. It's not significantly obstructing the airway. I'm gonna follow here. Is that okay? Like,
Yes.
I'm sure annoying. Sure. I should get, no, stay away from annoying.
Okay, stop.
Stop right there. So here, go ahead.
Tube opening. It's right here.
Okay. This is where we would see adenoids, right, in the rhinopharynx, and she really doesn't have anything obstructing the airway. I like to do the Miller maneuver, so I'm just gonna go all the way here, I'll pinch the nose, but just looking at her, anatomy, you can see it's bean shaped, right? So I would expect much more of a, endoposterior collapse than having significant, movement from the sidewalls, right? So I'll pinch her nose.
Well, you mentioned how you can kind of decide what the palate orientation is from that perspective. What as far as like oblique versus.
Oh, yeah, absolutely, yeah. So, this is where we look at something called the alpha angle, and it's how, sharp of, an angle you have here. And this is that image that I showed you guys, right? So you don't have a significant, break
Oh, shit.
here. So I'll pinch your nose for a quick second. And Scotty, if you want to compliment anything, I feel bad because, we're Sally here.
Don't worry. Okay.
So keep breathing through your nose, and now I'll pinch the nose for a second, and this tries to create negative pressure. Breathing through your nose now. Perfect. This is called the Miller maneuver. We'll do it one again. I'm pinching the nose, and I'm trying to see. Breathe again. There. And of course, it has limited. It's not, natural, but we're trying to look for more collapsible points. So now I'll go down a little bit, and I can see tongue base. I can see oropharynx, and it's
The glottis.
and here I'll usually describe how much I can see of the vocal cords in natural position, and I'm seeing really just the posterior part of it. Okay, so I'll have you stick your tongue out. Okay, tongue base, we usually have epiphyseal tissue here as well, and I have to do a long and that moves the glottis forward, and I can see the whole vocal cords. We're almost done. Okay, this is the kind of the going part. So these are the main points that we'll be looking at during the exam.
Tom,
Okay.
can you go up to the palate?
Yeah.
And can you have her push out? her tongue? I'm looking at
Yeah.
the
Go
palate.
ahead.
Push out your tongue.
Yeah, and that's for the couple,
You know,
right?
if it opens up there, it opens up
Yeah.
lateral. I mean, why would pushing your tongue out, open your lateral pharynx? That's
Yeah.
wild.
Yeah.
That's all the connections. that go
Yeah.
there. And
Oh,
then-
I see. Yeah,
And then,
absolutely.
and then what is there an exercise out of, Sao Paulo that she could do? How about touching your.
From Geraldo
Right,
group,
so
yeah.
touch your tongue to the roof of your mouth,
Go ahead. Here, let me look down.
okay? Well, that's good, that opens it up. Sure.
Yeah.
And then put your tongue to either the left cheek or the right cheek and push.
Can you guys see the variations of those movements? How it reflects?
Now, voluntarily, Sally, can you make your palate concentrically collapse?
I do it in clinic, I've never done it on the scope, let's see. Trying to make those.
That's close, that's
That's
close.
close, yeah.
So what were you doing to do
Pushing everything in.
that? So concentric collapse could either be a passive pushing in or an active pushing in, right?
Okay.
I'll take it in I'll take it up because it gets to be annoying.
Yeah. Yeah.
It gets so much.
Thank you, thank
so-
you.
All right, who's next?
Appreciate it.
We did all the
That's
I wanna
exercises.
ask, so, we see lots of these. This is a different size, like, how does this compare to like, we have the gray scopes are kind of our smallest, is the diameter?
How's this?
So the Rhino Slim, which he has right now, is I think 3.5.
Yeah, it's a little thinner.
A little thinner in.
Yeah.
So it's a little thinner, it does not have a port, so you can't suction.
I see.
Yeah.
But frankly, these sections are terrible anyway, so.
Right.
Probably there.
This is really just for like a laryngoscopy.
Yeah.
Yeah.
And we can in the office, I do it more than Thomaz, I think, but we can actually look at the trachea and look at even distal airway stuff.
Maybe I should have, sorry.
Wait,
I could have a free scope.
Wait,
I And sometimes with the kids, they'll combine, you know, the ENT and pulmonary will come, because it's so hard to get these kids sedated and both bronch and scope, and do a laryngoscopy at the same time.
Do you guys have any more questions? I'm happy to, discuss.
So
Yeah,
this,
points.
this is disposable.
Yeah.
And so what, $150?
Probably more than that.
I don't wanna say
Well, but
30.
Yeah,
Yeah.
probably closer to 300.
For the nasophryngoscope?
Wow.
Yeah,
This one I think.
Yeah.
Disposable bronchs are like around 5.
Yeah.
So it's $350.
We get a discount.
Or maybe,
I
yeah.
wanna say the simple, the small bronch is 380, this one's
Yeah,
230
but we
or
have
something.
like, yeah,
Um,
like the ones that make you the.
'cause we have a special contract then with. So, they're still not cheap,
Right.
and there's a lot of this, disposability,
Yeah.
waste. And but as far as like usability, they're fine.
Oh, they're good. The quality is good.
And they provide the monitors for free.
Because they can provide the scopes.
Yeah.
They got,
So,
They don't,
That was helpful, and hopefully, this is what you guys do every day. And sometimes wish we could scope in clinic, because, you know, we just kind of do the, we do the.
I mean,
It's-
these are not
Yeah.
that,
It's a lot of fun to scope
Yeah.
patients who are implanted. It's so much more fun to do a dice on an implanted patient, because we're changing settings, we're seeing how this moves on, how this stabilizes. It's really is fun.
Yeah.
so at the chess meeting a couple of years ago, 6 years ago, I was teaching a pulmonologist how to do in-office scopes, and it's actually a really nice tool. If you just, for lots of different reasons, you don't cough, and,
Right.
you name it, I mean, being able to look at the larynx. We, our cough guidelines, we don't have looking at the larynx, it's just kind of weird. It's interesting. We do chest X-rays, but we don't look at the larynx. Tumors can cause cough, I mean, all sorts of things, but, I mean, it's a helpful tool. This, I think, it's a phenomenal thing to assess people who are not tolerating CPAP, because it's hard to see the epiglottis and what's the epiglottis doing during sleep.
Yeah.
That's one of the things that I think, my personal experience in the military was that, a lot of these younger patients who can't tolerate CPAP is the epiglottis as well.
Yeah, it really was dice that showed how much epiglottis we see, collapse in the airway. It's supposed to be, literature would say up to 11% of patients have epiglottis component of collapse, so we didn't know, right? When they're awake, everything looks okay, so yeah.
even when they're asleep, it's up to 10%.
Yeah.
Well,
Yeah.
So the goal is to get the airway open enough so it doesn't interrupt sleep. So that's the.
Yeah.
Issue.
What are the barriers to getting people who are not tolerating their CPAP to be assessed well?
Oh, it's not, I mean, what we don't have is stops on any of those attempts to get it back on CPAP. I mean, should we just say anybody who doesn't want to use CPAP gets a referral and a look, or then the other is if the person's been using it for a period of time, and then, it depends on your symptomatic response. If you're using it 60% of the time, they feel okay. I don't know if you do that, so you have to sit there and say, are they symptomatic, not using it very well, and then do they want to, when they tolerate an examination first by you guys, and then whether or not dice. I mean, you want an 87-year-old with heart disease and COPD, you sort of sit there and go, wow, maybe we can try something else. Now, over the VA where you don't have as many ability to refer, they use things like bongo for mild disease. So, it's there, and I think the bongo is an expiratory pressure. It's you can breathe in, but you can't breathe out. It creates a back pressure, keeps the airway open, sort of inspiration. So there's something called LPAC, which is a similar sort of thing. It takes some time for people to, well, first of all, if you give out 100 of them, 2 people say it works wonderfully. So it's not as though it's high yield. The VA, they don't have to pay for it, so there's no barrier for that. And then the LPAP is the same way. And those are people who can tolerate something on their nose, you know. Whether there would be other, it depends, if they're if they're not surgically adverse, which some people are. Then there's no reason why not to send them. But often, in the past, you send them and they would get a procedure, you go, well, they got a nasal procedure to get their CPAP to use better. The definition of which one worked is not there. Even the reports on those nasal procedures to make them use CPAP better, what's the outcome in those people of their CPAP going from 30% to 70%?
Yeah, it's not.
I can't think of an article on there. There must be an article somewhere. But those are the issues. And certainly nasal surgery helps people breathe better when they're awake. They all know that they have less dyspnea, less mouth breathing, they feel better. So that's okay. It's fine.
I think one of the biggest barriers is the surgically adverse population. And they, you know, they think of being under and having this major surgery. And so some of the time I will sort of debunk some of that. So if you can help us explain sort of the minimal procedures that you can do in the office. You know, one I think of is inferior
Yeah,
turbinate
terminate reduction.
reduction,
Yeah.
right? And
Yeah.
you're sort of in and out during, you know,
It's
same
absolutely
day,
in and
right?
out, yeah.
So there's certain things like that patients don't always think about.
Yeah.
They think it's gonna be this huge operation with an overnight stay.
I'll be happy to see, you know, the 88 or with
Yeah.
conditions that I can't really do much. I can't do MMA, but I can definitely do something to improve nasal if there is significant nasal obstruction.
Mhm.
Turbinate reduction is one of them. It's as as what you had. It's not too bad. We do local and we'll do radio frequency, and that's pretty much it.
It's great, it's great, yeah.
And then there's gonna be some crusting, but I do expect it, the turbinate to be a lot smaller, so it doesn't matter.
That's great. And the other thing I think of, and we, you know, and I'm guilty of this too, is that we tend to refer later on in the process rather than early on. And so even if we're doing CPAP, maybe there's just better management when we manage the nasal breathing.
Yeah.
To optimize breathing with CPAP, but we often think about it after failure of CPAP, and maybe it's earlier, you know, time to refer.
So just as a question.
Question, the turbinate reduction, they have to come back, do they have reoccurrence of that turbinate enlarging and have to come back for?
Yeah, there is a chance, so we do follow up, but it usually will last years. If it's starting to go back, usually sprays will improve, and of course, if you try sprays and it already shrinks, you're not gonna suggest anything surgical. A lot of patients, they're already so enlarged that sprays won't really do much. It's a simple procedure, and I think it's, usually patients are happy with it, yeah. And then, you know, and the idea is to be progressively aggressive as needed, right? And as patient tolerate, but a lot of times, you know, septoplasty and turbinate will be more than enough. Sometimes you have to do bigger surgeries to reconstruct internal nasal valve, but usually, you know, I tend to choose for less is more because it's easier on patient, absolutely.
Thomas, you had a slide up there that mentioned the Inspire device and age, and there was I don't remember the exact quote, but it's like, you know, as a younger patient, you have more
Yeah.
potential problems over the years.
Yeah.
So, I mean, would you say that you find in a younger patient, you're more likely to steer them away from and Inspire more
Yeah.
towards other either bony or soft tissue surgery?
Yeah, we, you know, coming all the way from pediatric, we expect to be much more anatomical, and as you age, neuromuscular. For women, there is a clear change in the curve of things after postmenopausal because of, you know, that's actually interspecies, right? We know how protective hormones are, and postmenopausal women will significantly worsen the support of the airway. So I tend to, I mean, I've implanted young patients, but I tend to, well, first of all, it's going to be so many changes of batteries If there's something clear anatomical, I would prefer going for that, for aesthetic surgery and suggesting, Inspire, you know, and patient's gonna have 7, 8 changes of batteries, and it's gonna be, having something implanted for a long time. We're doing later, longer follow-up with, complications on Inspire, and, you know, you see more complications on patients who be implanted for a long period of time. You can see complications, so I tend to be very happy about implanting an older patient, but not as much for a younger patient. If there's something else I can
What are the
offer.
complications do you see with?
So the 50% by the mod, they looked at, 50% is the sensing lead. That's something I'm very,
Yeah,
not
trying to
happy
get
about
rid-
the
trying to get
sensing
rid of it,
lead.
Yeah,
The sensing lead can dislodge, can
so
move.
I think they're done.
They supposed to be done for a long time, but yeah,
Yeah,
it's more surgery. I
I
think
think it's
it's,
got a recall.
yeah.
Yeah.
And you know, there are new technologies coming out there, and every technology is gonna be a little bit different. There are technologies without leads, sensing leads. So it means less surgery. The sensing leads is what's gonna synchronize the stimulus with the breathing, right? Whenever you breathe in, that's when it's gonna fire. It's trying to mimic phasic activation of tongue. But even all these concepts, and Kingman can speak about it, all of them are not necessarily based in physiology, so it's something, and that would mean less surgery, and, you know, sensibly breaking is a common one, in very active patients. I mean, common, these are not too common, but you can see a little, these are rare, but
Well, they do occur.
they do occur, and when they occur, it's not.
Oh, how bad? Or dislodged or fall or people fall with their arm up.
Bench press, I have vision of
Yeah.
bench press and sensitivity chain and things like
So
this.
the postmenopausal women, fifties and sixties did better than men in the ADHERE trial, right?
They did, and why is that? It's the same thing on the other
Well,
one.
they thought that it was because they had more laxity, so that the tongue moving forward was able to couple the opening of the nasal pharynx. I mean, I think that's really what I think is interesting, is moving this forward opens up your lap.
They also have better compliance, right?
Right.
The younger patients don't have such good compliance. We, especially with the Inspire cloud system now, we can look at someone's compliance. And it's a pity to say, but ladies do much better than guys, you know? Ladies will use the whole, because there is a compliance, you know, as well, not as bad as CPAP, but you definitely need compliance, right? You need to use it.
But the original worry was that whether or not people were bad with CPAP, they would also be equally bad with Inspire. So that was, because both of them had to have something you put on before you go to sleep and turn it off. That's the factor. So where do you think the new stimulators technology is?
We need more targets, right? I mean, that's coming, it's gonna be Nixoa and Livanova.
Yeah, but the ones that are targets for the hypoglossal, they're developed in phase 3 trials, are they?
Yeah, Livanova, I think it's gonna be, you know,
Might be approved.
results are similar. It's a little bit less invasive surgery. We've done it here. We're part of the clinical trial we implanted. And it's interesting. It's definitely an option. I really like the idea of bilateral stimulation. Why are we stimulating only one side of the tongue? So we have a different device that it's a different incision. You don't have to implant the battery. That's also very interesting. I had a patient that told me, I don't want to be the Duracell bunny. I go, okay, I get it. I don't have a battery implanted on me.
But you just want to have one on your neck.
Yeah, I just want to have that.
Duracell bunny on
So
your
where
neck.
does the battery go? Right.
It's a little.
You attach.
Okay.
Yeah, as you go to sleep, you attach.
It's like a matchbox.
Yeah.
Ah,
It goes-
Okay.
So you don't, so yeah.
Huh.
It's gonna be, that's where this
Inductance.
field's gonna,
Okay.
yeah, move towards, less invasive, better technology. I think we'll get there eventually. When I left California, we were looking at transcutaneous deployment. So, you know, with our ultrasound, you guide it where you wanna, because all you need is something to stimulate the nerve. So you don't need to put a whole apparatus with sensing leads and all that.
Sure.
We'll get there. Inspire technology, I hope this is not being recorded, but it's old. Right? We can absolutely use newer and more interesting. It's already used for different types of stimulation, neurostimulations. You gotta bring it to sleep.
At least they've advanced from the 3 incisions down
Yeah.
to 2.
But that was done by ENT, right?
Oh,
And
yeah.
a lot of people here had to do with that. That wasn't, you know, Inspire who came out with that.
Right.
The ENT said, wait a second, why are we going
Why don't we just do the sensing
Greater-
from the IPG?
I'll inspire came up with the idea of having a sensor.
Exactly.
Sensor. It was an engineer that thought this.
Yeah, that was so important. Agree.
That's exciting.
Yeah.
That's great. Well, thank you so much for this. It's, I think it was a wonderful lecture and great
Thanks
anatomy.
for having me, yeah. Absolutely.
Mhm.
So I would like to try to write up, I have somewhere in mind a protocol. Healthy people look at their nasal pharynx during these exercises.
Mhm.
And then voluntarily being able to change the shape of the airway.
Mhm.
I know Denise can make her tonsils fall into her airway and come out depending on whether she activates or inactivates her style pharyngeus. So.
Yeah.
and there's- That's so the idea of, does this airway shape reflect? Everyone's assumed that it somehow relates to a tissue filling mechanism that produces the narrow. But if you look at whether or not the stylopharyngeus is strong or weak, it could be that stylopharyngeal weakness permits the airway to narrow down, especially during.
It's a very complex interplay, right?
You know, what we can do going through it is every time that you're at one point, you stop and you say, okay, what's underneath the mucosa all the way around? It's fun to do with the 2 or 3 ENT guys,
Yeah.
because sometimes they disagree.
Yeah.
What's underneath there? And they go, oh, no, that's not it, that's not it. And then you go down a little bit further and say, that's where it is, and okay, where's the attachments of the top to the palate, where's the attachments of this, and these are all underneath the look, underneath the look, and the epiglottis is fascinating. I mean, my note was, how does an epiglottic collapse develop? I mean, do you have that when you're 20? I mean, there probably are people that have positions of their epiglottis that are different. And is it because they swallow differently, or is it because they now are developing a neuromuscular issue that, or is the hyoepiglottic ligament somehow loosening up that potential
Yeah.
space between the epiglottis and the hyobone? Is that somehow not there? Because, you know, in terms of your procedures to pexy it, that is to pull it back or shape it, or to do plastic surgery, or put in, even some people, it stents into it to keep it from falling.
Mhm.
And so you kind of go, does that really how do you get there in the first place? Again, this idea that you just have to keep the airway open enough so it doesn't interrupt sleep. Doesn't have to be too big. Because peak crit really determines whether or not you're gonna have an AHI of like 10. But the rest of it determines whether you're gonna have an AHI of 40. So that's why the Inspire is on. Because of the other factors that propagate apneas over time during sleep. That's how. All right.